can you imagine what we would be able to do, the collective we, if we come together to define common advocacy agendas?
How do you invest in communities whereby what is being done in the community is not seen as investment, it's not seen as data, it's not measurable?
Now we want to be partners in whatever you want to do. We want to be partners in tables with you, not just involving us or engaging with us.
We're here, but our folks at the airport are being stopped.
Most times when these funds come out and they go to these bilaterals, already 50% of the money is gone.
We are tired of models, formula, mathematical equations that promise a lot and deliver nothing.
Trans people continue to be shifted from one little pocket to the other, to the other.
How do you expect them to successfully implement those programs when you are not even building their capacity?
You need to find the organizations or institutions or groups that have the capacity to absorb a certain amount of funding.
I'm sick and tired of hearing that we don't have capacity.
What's stopping you from talking to us? We're here.
I want to welcome you to sunny Harare. I think by the mere presence that we are here today, by the mere fact that we made it here and we're having this gathering, it just goes to show how much our movement is resilient. It shows how much our movement is ready to push boundaries, to push borders, to go the extra mile to attain our rights as key populations.
It's critical over the next few days that we find the ability to claim our identity, to claim our voice. Already there are challenges in key populations being able to claim that in the village. It might appear to be a very small issue in terms of there being question marks as to whether there will be a key population networking zone or what the booths are going to be called, key population M or key population S. But that we should not accept, because, as Dorothy said, she wants to be able to stand up and say, I am at ICASA as a sex worker. So over the next 2 days, we are going to be trying to answer that question of investing in communities, investing in you, investing in your programs. Why is it important? Why does it matter? And your voices are critical for each other to hear, but also for donors and partners to understand what your priorities are.
I think for us today, this is a very special occasion for us. In the 25 years of the movement existing in Zimbabwe, this can only be the moment that sort of really makes us feel proud about the work that we've been doing. These are the faces of the movement in Zimbabwe. They're carrying the flag for the key populations here in Zimbabwe. And I think we might be key population S, key population M. Let's not worry about that too much. because we've also existed as worse than pigs and dogs. So you can imagine. I hope that you feel comfortable in Zimbabwe, of course with the measure of, it's not always easy to be in these spaces as key populations.
In some parts of sub-Saharan Africa, the prevalence amongst young men 18 to 24 who have sex with men is around 6 times higher than HIV prevalence amongst other men of the same age. Prevalence amongst people who inject drugs. We have a real scarcity of data on all key populations, but particularly I think on people who inject drugs. But we know that HIV prevalence amongst people who inject drugs is relatively high. Unfortunately, a number of countries in East and Southern Africa region have no figures or estimates for this population. So particularly I'm looking at Eastern and Southern Africa. The legal environment in most countries is still hugely unsupportive, and there's been an increase in policies around criminalisation of HIV infection as well as same-sex relationships. In some cases, stiffer penalties have been proposed than were found earlier, indicating there's a growing misinformation and intolerance in the region. Probably even more than people who inject drugs, there's very little data on trans communities, and also if you're looking at engagement in and national strategies, and national aid strategies actually addressing trans people, you can see that they're not recognised in most national strategies. Next slide, please. Okay, so this slide here just shows you the availability of needle and syringe programs. Harm reduction services are mainly not widely available, only in South Africa, Tanzania, and Mauritius.
We were a founder member of the Global Forum on Men Who Have Sex with Men, and we wanted to make sure that there was a global group that really was able to take forward some of the questions. Also at a global level, we established a global reference group on HIV and sex work, basically saying there needed to be a formal mechanism whereby sex workers across the globe could represent their issues to the UN system. One of its implications, I think, is that it will no longer be possible. There will be a set of mutual accountability in relation to national and local responses to the epidemic. It will no longer be possible to say that for political difficulties or for reasons of concerns about taboo or for reasons of concerns about we're not sure that we want to talk about behaviours that we don't want to encourage. I think we're very much clearly saying that it is no longer possible for credible AIDS responses to use those excuses. And so for countries across the African continent, it is absolutely clear that if they are to be seen to be making progress in relation to the fast track to ending AIDS, it is progress which will have to come with, be accompanied by, and in many respects led by, the key populations of those countries concerned.
Why can't Global Fund come up to fight for the voice of key population by putting some limitations for the country to qualify for the Global Fund must have several guidelines, including the criminalization of key populations. Drug users were not included in standard Global Fund concept, using the evidence that there are no evidence for people who are using drugs. How are we going to be involved when they keep saying no evidence for people using drugs?
How does Global Fund want to ensure sustainability within the KP organizations? Because we can't keep over the years saying we do not have capacity. What happens to the capacity that has been built over the years?
We can't get as Global Fund go into countries and demand that countries do things. So we can't demand that countries will be criminalised. But what we can do is provide funding to organisations to actually work towards removing some of the barriers that are impeding access to service, such as the bad laws and policies that exist around criminalisation in a whole range of ways.
when we speak about decriminalization, that is not paradise for key populations. That is just but a taste of what human rights means for us. We are here, but our folks at the airport are being stopped too, and they're calling us thingies at this airport. Like, why would people need to bribe behind and give out an extra $50 just so that our communities can actually get the opportunity and the space to share information across our countries in a space that is an international HIV and AIDS conference on this continent, a continent that is severely affected by the pandemic. It is unacceptable. And if we do not come out of here to say no, then we have failed generations to come.
KP communities are subsidizing the HIV response because we give of our time in ways that are not appreciated and not valued. And yet, despite all of this, we are still asked to prove that investing in communities has an impact in ending HIV, in strengthening health systems, in uptake of services and treatment. We exist in contexts where we have to overcome enormous policy, systemic, social barriers that continue to exclude us from public healthcare systems. In many of our communities, public health facilities are no-go areas. We're talking about strengthening health systems. Nurses, doctors in many countries have also become law enforcement agents. So you present with an issue as a key population, the first course of action is to call the police to arrest you because somebody thinks that you should not be in a public space. Somebody thinks a crime has been committed by the very nature of your existence. And these are the issues that exclude us across the continent from public health facilities and private health facilities. And if we do not address these issues, whatever other investments we claim to make in strengthening health systems, we will never achieve the end of AIDS. So we've resorted to running healthcare centers. We've resorted to even training government healthcare practitioners. I mean, maybe at some point we should start a country because we are a state almost.
The current status quo, as you will know, would be one where trans people continue to be shifted from one little pocket to the other, where there doesn't seem to be a space where they fit because many of us continue to say we are LGBTI, we are key populations, and as such, trans continues to be consumed and subsumed under a whole lot of messaging that does not necessarily address directly the specific needs of trans persons when it comes to the HIV responses and programming that we're working on. So if you look at how at this point in time we continue to go to different fora and spaces that says no data when it comes to trans, no data when it comes to intervention specific to trans people, we're not sure, but we will appropriate something that is closest to that. The question then becomes what exactly is it that is needed to ensure that then there is specific data on trans people, there is specific evidence on trans populations, and there are indeed representation on various levels of trans communities. It comes down to the very person who has a PhD that they've accumulated out of a lived experience, a lived reality of being in spaces that do not understand that trans is not just about transsexual men and transsexual women or trans men and trans women. That we have within the trans community itself a variety, a wide array of identities and expressions that even right now as we continue to be in different spaces that are KP focused, you often are realizing that it's easier, it's much safer for people to just say, and the transgender community or and the transgender people, which continues to then invisibilize this whole diversity within the trans umbrella and within the trans spectrum itself, that then with that it means every single one of our interventions, every single one of the messaging that goes out there does not speak to the trans community, but it speaks to a certain subsection of that particular community. But then the question is, why has that continued? Why has that perpetuated? Because there's been people who continue to speak on behalf of trans.
The law is not protecting the sex workers. The law is fighting the sex workers. The law wants to put down the sex workers community. It is sad when you go to a cell, when you are a sex worker, paralegal, or a human rights defender, then the sex workers have been jailed for 3 days, and they shout for their drugs. They have stayed for 3 days without taking their ARVs.
I just want to ask if in Uganda it's possible for trans women to access hormones.
No, I don't think I
can
didn't
explain that.
Yeah. Yes. I was going to refer that to you, but I was going to tell you that I don't deal a lot with service delivery, and not specifically to the transgender community, but I can refer you to Bad Black. Yes, she does that so well.
Okay, in Uganda, we only have one transgender woman who has transitioned fully, but she didn't have it in Uganda. She had it in Thailand, and now she's staying in Kenya. She's currently working in Kenya with some organization. So in Uganda, we don't have services for transgender people, especially when it comes to hormones. It's not even anywhere.
So the question from the colleague from Juanetta, how can the Global Fund help to get human rights interventions into the concept note? It's a very good question, and one we've been grappling with, I think. We've been clearly more successful in some countries than others. And when you have governments who do have repressive policies and legislation, sometimes they're not too keen to have funding coming in that's actually going to be supporting communities to challenge them. So it can be tricky.
In Uganda now we have stockouts, drug stockouts in most of the districts. For example, last week is when I went for my refill, and I was given medicine that is expiring in December, this December, but it goes up to February next year. And then I asked the pharmacist, how comes this medicine is expiring in December and you're telling me to come back in February next year? He was like, okay, with the medicine, they give it an allowance of a month, so even if the expiry date is December, you can still take it up to February. I'm like, come on, I went to school, I know how to read. If it says it's expiring in December, why do you force me to take it? Just tell me there's no medication. I said, yes, exactly, that's what I was about to tell you. We don't have medicine, so you keep that. If you fear taking expiry medicine, you will bring it back in January. And if we have, we will change for you.
So, what are these new prevention technologies? I think these are what we formerly were mixing with what we call combination prevention, those other technologies. So we wanted to specifically iron out and really differentiate between the combination prevention, because combination prevention actually involves as well structural issues, the behavioral component of it. But we wanted to talk about the real components, because all these other issues, all these other technologies are really adherence-based. I can remove the rectal microprocessor, I can remove the ring, or I can stop to take the pill.
He's asking, he heard Daisy saying that some sex workers were being murdered. He was wondering, murdered by who exactly? Is it the client? Is it some mobs? Or who exactly are killing sex workers?
Overall vision of KP Reach, like I was saying earlier, is to ensure that there is KP-led intervention and work that will go towards tackling the high levels of HIV within sex workers, men who have sex with men, women who have sex with women, and the transgender community. We believe that KP-led organizations should be the ones to drive the very interventions that are meant for them to tackle HIV and reduce.
I stand in solidarity with African key populations, sex workers, men who have sex with men, trans diverse persons,
I'm taking away that you just can't underestimate the power of community, the power of people coming together. And for me, this was a truly historic moment.
Given the environment that Zimbabwe portrays on LGBTI people, I think just the mere fact that this conference has been able to go through these 2 days is a huge success, and one that goes down in the historic achievements of key populations in this country, because we've created a reputation that Zimbabwe is not a safe environment for LGBTI people. But having this conference, I think, is testimony to the fact that there's certain things that can happen in this country where people get together and talk about issues and look at addressing the challenges that might be presented on these difficult issues.
The fact that over the last 2 days, we've had a successful key populations pre-conference. We have concrete outcomes that are coming out of this pre-conference that we want to carry forward into the main conference in ICASA, towards the community villages. We'll be sharing the same message across all key populations, saying the same thing. I think that's a very powerful message that our governments need to begin listening to, our partners and allies need to be listening to, in order for us to actually make the change and the impact that we want to achieve in ending AIDS by 2030.
We believe that there is need to have a human rights lens in the approaches that we are using in terms of all interventions relating to key populations. We are speaking to the voice of key populations being heard in programming and bringing up the issues in all the consultations and sitting on the table as equal partners and ensuring that there are no violations that are perpetrated by state or non-state actors in terms of having a meaningful response to HIV. And I believe that we will not get to the targets of reaching 90 by 2030 if we do not meaningfully engage in a human rights lens with key populations.
Traditionally, people have said, and this has been given as a reason why there isn't an investment in communities. They say they don't have capacity, they cannot work together, they're fighting against each other. We have used this pre-conference to show that we can come together, that we actually do work together. And that is powerful, that sex workers, people who use drugs, trans diverse persons, MSM, LGBT, lesbian women, women who have sex with men, despite our own individual issues, we can come together on the things that unite us and move a common agenda.
So is AMSHeR a regional organization or a national organization? So what does key populations mean? So that you can get a picture.
Key populations means marginalized population like the LGBTI, population, the disabled people, adolescents, those are the key populations.
Those are not the key populations. So the key population are the people who are considered as most at risk within the fight against HIV, and those are MSM, LGBTI, which include MSM, transgender people, sex workers, and people who use drugs. What are the three main key populations found in Africa? Good. So you have answered correctly. So why answer correctly?
Hey guys. Hello. Hello guys. Can you hear me? So I'll speak on the young MSM. All of you have had young MSM are the most upcoming people who are MSMs and most people deal with young MSM. The older MSM is mostly empowered, but the young MSM is left by to come closer to suffer down. Because of one thing, the older MSM mostly is empowered more than the young MSM. Why? They're from the older generation, they are landed, they are not out yet, they are family, but the young MSM is still coming out trying to identify his weaknesses and coming out the family.
So we've had a mixed reaction, especially with regards to immigration and airport transfers for most sex workers. We've had a few incidents. One, most of our materials were confiscated on the day of arrival for no reason. And secondly, we've had some transgender sex workers arrested and detained at the airport and questioned by immigration officials over why their gender and how they appear is different from what the passport says. Despite this, we've had a marathon of meetings with government officials, members of the National AIDS Council from Zimbabwe, to try to iron out some of these issues. So there's been some logistical issues, there has been some airport issues, material issues, but so far things are okay. We haven't had any incidents, major incidents to report about, but participation has been awesome, it has been amazing, and I would really like to thank everybody who has made this possible.
Here's a snapshot of the challenges, saying that Fast Track talks about test and treat, but how do you test and treat a hidden community? And if you want to, and how do you get to a hidden community when it's criminalized? Where we have standalone sex worker clinics, they then become targets for violence, or they become targets for discrimination from the wider society.
The encouragement to go to other regions, to go to other KPs. That's indeed our true intention. But let's indeed first embark on this journey. And cheers to that. Cheers to everyone.